Next, I'd like to introduce Marge Good. She is a nurse consultant in the Division of Cancer Prevention and has provided support to the community clinical oncology programs and minority-based CCOPs, and now provides supports to the NCORE programs. She has over 30 years of oncology nursing and over 20 years of prior experience as administrator as a successful CCOP. So Marge is going to talk with us about professional career ladders in the clinical research professional realm. So please join me in welcoming Marge. All right, well done.
Hello, everyone. I've done this a few times, and so I never go without my flash drive or my thumb drive.
Smart.
Thank you for inviting me. Jennifer, I don't think we've met in person. We've done tons of email, so it's nice to meet you in person.
Nice to meet you.
It's good to be here today. I used to go to the NCCTG meetings all the time, so it's like I haven't been able to do that since I shifted to the NCI almost 9 years ago now. So it's been a little bit since I've been able to see some really friendly and familiar faces, so I'm glad to be here. So today I'm going to talk about career ladders and kind of in the realm of using it as a staff retention strategy. And I'm not going to stand up here and say I'm an expert at this. We did use career ladders a bit in my previous life, but I think I presented some of this information at our last NCORE administrator, or at last NCORE large meeting last September, and I think I was asked then I must have been considered an expert, and so I was asked to do it here again. So I did a bit of research to try to put this together, and you'll see in my slides that I put some reference names and things, and at the end is a whole list of references. If you want more information, hopefully you can go to that and find out more. I'm just curious before I start, how many of you in this room know or utilize career ladders within your institutions or where you work? Not a lot of hands. Okay, I was kind of thinking there might be more hands than that. Okay, so let's get started on this. Whoop. Oh. How do you go back? Okay, there we go. So I wanted to just give a little bit of a background, but a fair amount of it is background. I think you need to understand why career ladders are important. Talk a little bit about turnover and its impact, and I think I could get every hand in this room to come up if we had to talk about turnover, because that's one of the most frequently reported issues that I hear from the NCOREs, is how to keep my staff. They're struggling with it. And maybe looking at some retention options and then focusing in on career ladders and some of the benefits. There's challenges, there's the ways, I found different ways to develop it, as well as maybe some real world examples that you can take home. And this, I found this graph or table visual that kind of says a lot, I think. It shows that initially most employees, when you hire them on, they're kind of costly because you've got to train them, you've got to bring them up to speed, get them to the level that they're productive for you with enough proper training and education. But over time, they become more and more valuable to you. So the goal is to attract the right people and move them up the curve so as rapidly and as effectively as possible. And basically, employees then are an appreciating asset that produce more value over time, which explains why losing them is costly, so costly. All right, now we'll go forward. So I found this also, I think it says a lot as well. It's a general healthcare industry really has had a significant turnover, and it's increased a lot, I think, when you look at the whole system. Over 5% in just the last decade. And so looking at acute care hospitals, the turnover rate is about 18%. In South Central United States, they have the highest regional turnover, about 19%. And North Central US has the lowest at 17, but still pretty high. Hospitals under 200 beds have the lowest turnover rate, about 17%, and hospitals with 350 to 500 beds have the highest turnover rate of almost 20%. Now it's going backwards. Okay, So when you look at the research realm, the CRAs, it's even higher, which explains why I'm hearing all of this from the NCORs. The worldwide turnover rate for a CRA is about 25%, and that was back in 2015. In the contract research organizations, or CROs, the 2016 average rate was 21%. And then when you look at a specific role as a clinical monitor, the turnover rate can be as high as almost 26%. So, and then you have to think about, and everybody in this room also, I think, has probably experienced some organizational changes going on. I hear we have constant buyouts and mergers and things going on, and those are significant organizational changes. And during those, the turnover rates can be as high as even 39%, approaching 40%. So yes, turnover is a problem, and it's very costly. To replace someone generally in a hospital, it's about $60,000. A bedside nurse, $38,000 to $61,000, and it can go up as high as $1 million when you're talking about someone higher level, like a physician. Non-healthcare, found a couple of quotes as far as entry level, it can be 30 to 50% of the annual salary. The higher levels can be as much as 400% of their salary. And another quote is 1.5 times the annual salary of the position. And also to go with that, the longer a job goes unfulfilled, the more it impacts the bottom line. So the emphasis needs to be on how to retain and keep people. Now I also found this I thought was very helpful, calculating financial costs. If you know can determine the cost of hiring a person, the onboarding and training costs, the learning and development costs, as well as the cost of the vacancy, and you know those numbers for 1 year, for one employee, you add them together, and that sum then, you find the total number of employees. So in this example, it's 100 employees, and the average turnover, annual turnover is 7%, which is pretty low after the statistics I just gave you. And you take that times your cost rate for one person. So in this instance, they lost 7 people in a year. That's $350,000 lost. Well, imagine what you could do with $350,000 and how many positions that could fill. So turnover cost is very expensive. But there also are non-financial associated costs. There's that loss of the future potential for that person that left, what they could have done for you. The negative impacts on the staff that's remaining. The morale generally goes down. It's frustrating for them. There's this loss of continuity, loss of knowledge, loss of productivity. There's this need to recruit and onboard, which takes time. And actually, companies generally lose about 17% of the new hires within the first 3 months. So there's this constant turnover, this constant issue that you have to deal with. And it takes time to get someone up to speed that they're going to be effectively working for you. I found a few competency timelines for Bayer, quoted 6 to 12 months, which I would go more on the end of the 12-month time period to get someone up to the level that they're productive for you. There was a cooperative group paper, I think it was RTOGs, they said 5.5 months, I think that's kind of low myself, and then industry setting was 1 to 3 months, which I think is really short. But it takes time. And then in the interim, there's increased workload on the remaining staff. There's a likelihood that there's going to be a delay in data submission with increased queries. The strong performers get burned out as more positions go unfilled, and then you have their turnover possibly. There's also this potential for a really negative reflection to sponsors. People want to come to you to do more research, but they see this huge turnover. Is there a management problem, or what is the issue? So why are they leaving? The number one usually is job dissatisfaction, and I highlight in red those that I think can be impacted by a career ladder. Number one is they feel that there's a lack of career development opportunities, advancement and/or promotional opportunities. There's a lack of engagement and/or purpose behind what they're doing. They don't understand what they're supposed to be doing. They're just not engaged. There's no opportunity for input into decisions that are being made. They're just dictated to and said, do this. There's inadequate resources. They don't feel like they're receiving a fair amount of salary for the effort and the work that they're doing. And they also often feel that there's inequitable treatment between and among colleagues. And when I talk to you about the career ladders, you will see that career ladders can address each of these areas. There's also a need for formal training. Most everyone, and that was how it was when I started 30 years ago, it was bad. I had a couple of really strong people I work with, but much of what I did and how I learned was on my own and by making mistakes. And when an audit comes in and says, no, you're not supposed to do it that way, and that's how you learned. So there needs to be better training opportunities. There's also often a poor allocation of workload. There's just an imbalance going on. Some people are not as busy as others, and those that are busy and trying to keep up just burn out and say, forget it. There's often an imbalance of work and non-work life, and they just simply burn out. There's also issues associated with personal reasons for why leaving a job. They're retiring, they're going to have a baby and they don't want to come back, or they're in the midlife crisis mode in a sense. Those that are in the 40 and 50-year-olds, they're thinking, is this really meaningful? This is how I want my life to be? And then they start thinking about other jobs and other opportunities. The other reasons they're leaving is they don't like their boss. I won't raise the hands in here for that one. There's also this issue of company culture mentality, that the needs of the business comes first and the individual's needs come second or third or fourth or fifth or wherever it falls in. The business extracts what it needs from the people. They basically are there to work for the boss. And they feel taken advantage of, and they leave when they feel that way. There's also more and more literature now on the millennials quandary. Millennials, they're those that are under the age of 35. Nearly actually 1/3 of hospital staff are millennials. They come with a different mentality than maybe those of us who are more seasoned, and how we came on board. We were like told what to do and we did it. Millennials are basically, they want to know why. They do not want to work to serve authority, they want to work to serve their own needs. And they have a choice. They want more than this, and basically they say, I don't know what it is, but I'm going to keep looking until I find it. And they do, they keep looking, they jump from job to job. So you have to offer them something they can't get on their own, something that helps them become part of a better vision for themselves. So also there's this issue of company culture shift. I think because of all these turnover rates, that healthcare industry is starting to wake up a bit and understand and listen, we got to do something about this. Historically, they've not invested much in frontline workers. They now know they're going to have to provide higher quality and at lower costs, and they've got to put a stop to this turnover cost that's really hurting them. And they need to address the staff shortages resulting, and all of that then is increased an interest in this, how to keep staff. There's also the nursing staff shortages and financial instability and emphasis on retaining competent staff. They basically can't afford to overlook this anymore, particularly looking at certification and clinical ladders that demonstrate that their commitment is there to provide high quality care and professional development. So with some retention strategies, a fair number, I was surprised by this, almost 22% of hospitals, only 22% of hospitals have actual retention strategies or considered them. Almost 60% focus primarily on the new hire and don't focus at all on those seasoned, the ones that they're experts, the ones that know everything and the ones they really don't want to lose because they know the basics and they can train the new people. So some retention strategies to consider along with thinking about career ladders is basically looking at self-assessment and team assessment, continuous improvement feedback, listening to the staff, asking them what the issues are. Sometimes I really miss the management piece because I miss that, talking to staff and finding out, getting to know them, who they are, what's important to them, and addressing those issues if they're having issues at home or whatever, being aware of those issues and just simply listening. Conduct stay interviews instead of exit interviews are important, but found a resource of looking at stay interviews. Talk to them and find out why do they stay with all of this that's going on, and what could change to make sure they do stay. instead of waiting for an exit interview, to talk to them after they've made a decision that they're leaving. Consider what to stop doing. Look at what the processes that you're doing and find out, for an example, we were a really strong nursing CCOP, had most of the nurses doing everything. Well, there's a lot of things they were doing that nurses didn't need to do. And so we hired on more non-nurse staff to take on the non-nursing responsibilities, so the nurses were freer to do the nursing responsibilities. We also just looked simply at what we were doing. And with a lot of the things we were doing, we did it because that's the way we always did it. Well, maybe we don't always need to continue to do the same thing. So looking at what you're doing, and conduct a gap analysis of knowledge base, what training needs are needed, where are the weaknesses, and then find those additional needs. Address the additional needs. Balance work and non-work life is challenging, especially when everybody's so busy and you're tired and dead from the day. You don't want to go out with your friends at night or something, your work pals. But just trying to find ways to make lighthearted work, try to go to lunch together different times, have meetings together that are lighthearted and not talking about work. And just being aware that the staff do have, if you're in management, that they do have another life, and they're not there just devoted for you. Cross coverage, task sharing between staff, and having flexibility, allowing people to work 2 to 3 days a week and share it with another person. So it's basically a full-time position, but filled with 2 part-times. It's challenging, but it keeps people on board. Team building events, regular acknowledging the value of each person, establishing competency statements. There's several out there that you can look at for nursing as well as non-nursing. And then to support and encourage certifications, so for oncology nursing certification. And then there's the career ladders. So the question is, do clinical ladders make a difference? There's kind of a mixed feeling in the literature, but I found more supporting it than not. The multiple reports reported that clinical ladders decrease costs, reduce sick time, turnover, and the use of agency staff, and they felt that they had higher staff satisfaction. A Norwegian group said that they had their turnover and intent to leave were much lower along with the staff that were participating in clinical ladders than those that were not. Pearson's group felt that it was integral to their facilities' recruitment and retention, their professional development and evidence-based practice initiatives. They basically were able to use it to provide evidence for their institution's magnet designation and then for its redesignation. So that was a positive. Another author said that they felt that it created an atmosphere of professionalism and self-improvement. And then Warman, who's with the University of Alabama, Birmingham, felt that this clinical ladder staff involved in patient care enhanced activities. They were in enhancement their activities, and they were part of councils and committees, and were participating in educational activities, and were actually moving on to become leaders within their organization. So there's definitely positives out there. All right, now where'd my mouse go? Okay. So let's talk about what the definition for a clear ladder is. It's basically it's a grading structure which facilitates career progression and associated differentiation of pay, usually, by defining different levels of clinical and professional practice. The progression is up hopefully, and is dependent upon meeting defined criteria of clinical excellence, skills and competence, professional expertise, and educational attainment. And this isn't really something that's new. Zimmer and Benner produced had evidence of journals back in 1972 and 1982, and much of what is done today is based on Benner's staging of clinical competence. It starts this is not a good visual. They start at the bottom at the pyramid as a novice with no experience. They're basically just coming in to expert level who's been able, now knows enough and has the intuitive grasp of each situation, and has the clinical critical thinking skills to think through the processes. So it's a grading up system. Many of the systems are 3 to 4 levels depending on the institution. There are definite benefits to clinical ladders for the employee as well as for the institution. For the employee, they gain skills and knowledge while they're on the job. It encourages and recognizes and rewards qualified employees, which enhances their retention and attracts more employees. It optimizes clinical performance, professional development. It incentivizes accepting additional responsibilities, and it really drives the development of new skills and knowledge. Improves job satisfaction and longevity, and promotes staff engagement in problem solving and quality improvement. They're part of the issue or the program instead of always being dictated to. And it also, as was shown in the previous, it's a roadmap for development of future leaders. And it's also, there's this potential for pay increase, which automatically when you talk to administration, they're like, nope. But after you see the losses they've had, if it's losing 7 people out of 100 and it's $350,000, I think that would probably cover the cost of the clinical ladder. So do you have an argument with that? As far as the institution, they have better trained workforce. It's an improved recruitment and retention of high-performing staff. There's improved patient satisfaction scores because the staff is more satisfied. It's reflected as a quality organization. They have less turnover, recruitment, and training expenses, and therefore they save dollars. And as I said, I think many of those dollars could go towards the development of the clinical ladder. And it's a greater return on their investment when it's actually structured to provide workers with meaningful wages, wage increases, educational attainment, and advancement within the organization. But there's challenges with career ladder development as well. You do have to get and have institutional and management support from the top all the way through the management level. You have to verify that there's sufficient infrastructure to support the development and maintenance, people devoted with time and resources to be able to make it work. And then you have to consider the compensation and recognition. How are you going to recognize these people as they move up the ladder? Yes, pay increase, as majority of them I think do have pay increases associated with the ladders, but it doesn't have to be that. There can be professional development offered. You can pay for their certification, conference fees, professional organization memberships, purchase books or educational materials for them, provide educational days off, or simply added vacation days instead of maybe an annual salary increase. And then always the recognition, adding the recognition on their name badge, as well as an internal recognition celebrations or parties type things to recognize them for their efforts. You also have to consider the workplace culture if it's going to support the career advancement. You know, you have to think about the workers, and they generally would have to attend classes on their own, possibly on their own time, and complete homework to be able to move through the career ladder steps, depending on how they're structured. And so you think about those that are at the front line at the lowest pay level, and will this be an increased hardship on them that they have to now expend more of their hard-earned money towards this, that they hope that they're going to be able to move up the ladder. And you have to consider the management, and you know, I've worked in management for a while, and you have those that just don't change much. They're kind of get stuck in a rut, and they don't think about a change in paradigm and how they want to work with people, and so they may actually hinder the effort or make their scheduling inflexible, so it prohibits the employee from wanting to be able to move forward, to get the extra education that might be needed. And then when they come out with moving up the ladder, management has to deal with this person who now, they used to be at this level, now they're at this level, and they have to recognize that and treat that person with respect for the level that they're at. Yeah, I think you also have to consider avoiding the endless cycle of training for upward movement. If it's not going to be meaningful career advancement for the person, don't demand that they go through all this training and then they really have nothing at the end that gives them the enhancement. Increasing salary is not going to compensate for a poor work environment. If the work environment is poor, it doesn't matter how much you're going to pay these people, they're still going to probably leave to find something that's more satisfying for them. So there is a process to development, and then there's multiple pieces of literature out there that give you ideas. I put together, try to summarize some of them into a slide or two. Again, getting buy-in from the institution, including an estimation of what the annual cost would be. Develop a task force, and with that, to include staff, administration, and human resources. Anybody, all of them, particularly the staff. Read several articles where the staff were not included, and therefore they didn't buy into it, and it just simply didn't work for the institution. You have to get feedback from the staff that's going to be impacted, and it has to be perceived as valued by them. Determine the number of levels. Again, I said average is 3 to 4 levels, and then looking at the qualification and the time requirements for each of those levels. What is the minimum amount of work experience for each level? Is there an academic degree required for certain levels? What type of specialty education is going to be required? Passing performance evaluations as well as competency tests. And several recommending having an exemplar, use of an exemplar where the nurse or the staff person writes about an experience that they've had maybe with a patient, and it reinforces stating and indicating why that experience was important to them, and also to share their clinical experience with that, what clinical things, occurrences happened with the patient and how they work with that patient to help resolve them or get the patient through the period of time. That allows the group that's reviewing to see the commitment of the person that's applying. And some institutions or some looked at a points system and maybe allowing extra points for those who are certified. If they've done community service, they've done some additional training that maybe wasn't even part of the clinical ladder program. Do you want a nomination process, a self-nomination, or do you have to have other colleagues support the person? What kind of compensation plan again? Application review committee membership makeup. Definitely, I think many of the articles suggested a peer review process. And then educating the staff that this program is available to them and getting the word out. And there's, again, this is another just simple pictorial of steps in a clinical ladder from another author. And I think what was unique with this was they actually pilot tested the process and got employee feedback as to, so they could edit and monitor it before they rolled out the final plan. And it's important that there's an annual evaluation, a maintenance, and an update to it. A clinical ladder program that remains stagnant is going to fail. It's not going to be as effective. The staff need to know that there's continued evolution of the process. And along with that, to always be assessing the employee perception. Do they feel like it's a quality program and it's fair in the promotion process? And do they feel that they have to put in an excessive time commitment, unrealistic expectations, or inconsistencies in implementing or evaluation? And they don't feel like the extra work, all that effort is equal to the effort. So here is an example of a clinical ladder for perhaps for a research staff and looking at a CRA. Starting out, and I kind of top down on this one. They start out as a data manager, advance to the CRA 1 level where they've had 0 up to 2 years of clinical experience. They have a bachelor's degree. CRA 2 is 2 to 5 years of clinical research experience. They also look at data quality, late data, error rates, and the CRA 3 is at least 5 years experience. They're certified by SOCRA. They've had cross-training completed, and they're involved in leadership tasks, and they have also the same, each of the ladder steps builds on the previous step. And then there's the lead CRA, again, with greater than 5 years experience, and proficient in all aspects of the CRA position. So that's an example for a CRA. Then I found several institutions. Warman, again, is at the University of Alabama, Birmingham. They have to work or be employed at least 1 year before they're eligible, and they have to remain at the same level for 1 year before they can advance to the next. They have to complete one level at a time. They can't skip levels. The manager supports the critical elements for success, and they develop the process, including lit review, staff feedback. Level 2 applicants provide a CV and have various, and level 2 gets a 5% above base monetary bonus. Level 3 has the same qualifications requirements as level 2, but additional contact hours, and they get a 10% increase in salary. They're also invited to a luncheon to highlight the applicant, and they get a pin, and they get a framed certificate. They have submissions 2 times per year, and it's a structured appeals process, so if the person feels that they've been unfairly reviewed, they have the opportunity to appeal. They design the program to meet the current needs of their organization, and they assign an advanced staff person to it. They have dedicated time to grow and sustain the program. There's a few other sites. Children's Health of Atlanta gets up to 8% raise with each move up the ladder. Cleveland Clinic, it's hourly rate. Tier 1 is 75 cents hour raise. Tier 2 is a $1.50 hour raise. UCSD, University of California, San Diego gets 2.5% salary increase with each of 18 competency steps. Pretty intense. So it's a lot of information pretty quickly, but I don't feel like I'm the expert in it. I would like to maybe hear from some of those who are in the audience that have dealt with career ladders, if they feel it's positive or negatives or frustrations that they've had with that. I just, in concluding, I think none of us in this room would disagree that turnover is really a significant issue, and it results in a loss of a lot of valuable financial and personnel resources. And institutions and administrators need to review their staff retention strategies, and I really think career ladders could be an option to maybe put a plug in this turnover problem that we have in the world of clinical trials. So with that, I'd really like to open it to questions or discussion. And again, I have 2 slides of references that you can have. Hopefully the slides will be available to them so they can go to those and read more about it if they like. Right. That's it. Any questions?
Can you go to the microphone, please?
Hi, Patty So from Cedars. Would you please comment on the gap analysis that you mentioned? That's one of the strategies we can do.
Well, I think it's and I'd have to look up specific. I'm sure there's examples out there that you can do. It's basically assessing where there's gaps in knowledge, and some of that you can get when you're looking at their forms completion or their understanding of disease processes, and it's kind of like a testing in a sense to find out what are they failing at, what they don't understand, what's leading to increased queries and issues with data submission and cleanliness. Oftentimes audits bring out there's a gap in knowledge for a person, particularly or staff person. I think there's formal documents out there that you can use to assess gap analysis, do a gap analysis on.
Hi, Kamara. I'm the Director of Clinical Research with Spartanburg, part of SCORE and CORE.
Yeah.
And we recently, in the last 2 years, started implementing a career ladder, and it was a big challenge, so I'll echo that you really need your leadership support in order to get those job descriptions and be very transparent with your team as to what you're doing. But we've successfully added 2 different job descriptions, and we have it set it up where we have a CRA, which was more like our data manager, and then we have a senior CRA. We added a clinical research coordinator that doesn't necessarily have to be a nurse because our team is very nurse heavy. And then we have a senior nurse and a team lead. So we have basically 6 levels now.
Wow.
And since then, we've also gone to our HR and asked for a compensation review for everybody. So we're just doing team by team to make sure everyone is at the level that they need to be at. And we've received a lot of support. So just wanted to add that.
And so your staff seems excited about it, or?
Yes, they are. And everyone's willing to take on a little bit more if they're, able to move a level up. So it's been successful in my opinion.
Good. I have to, from my own experience as well, I mean, we had a bit of a ladder when I was in Wichita, and it was a process. We had to go to HR, we had to write up the job description to fit each level. Then we did a national type search. I actually found titles or job description titles out there, so we weren't making up new titles that HR couldn't find anywhere. And so we did a search to find out what were some of the common job titles and then their job descriptions that went with them to see what would fit with what my staff was doing at the time. And so I think we had like 2 levels for non-nurse CRAs, and then we had 2 levels for nurses. And then we had we had cancer control focused nurses that maybe didn't have to have as much of a strong oncology background, and then we had the treatment nurses who really did need more of that oncology clinical understanding to manage those trials. And so the cancer control nurses were a little lower salaried than the treatment nurses, which we had several of the cancer control nurses educated themselves so they could move up to the treatment level. And some of the cancer control nurses were quite happy staying where they were. They loved it. And so that was fine. But I think it also helped with the CRAs. They really wanted that other level to move up so they could. We did have a salary increase with each of those, or a change in salary for them. And so it did help make a difference. All right, well, thank you very much, and I wish everybody a good meeting for the rest of the meeting.